Presenting a revision THR case, how do we progress it? Yeah, so that's a 63-year-old female, primary hip replacement done for osteoarthritis 9 years ago. Patient comes to us bedridden, that's her AP X-ray. And that's the lateral X-ray. Infection check, no infection, CRP, ESRs are normal.
Okay,
Go for CT scan?
Yeah, you have a CT on.
Yeah, I do have CT.
Yeah.
So I thought you're going to talk about something about X-rays. So apparently, X-rays definitely shows a bit of pelvic discontinuity. Gross loosening of the acetabulum is there. A gross protrusio is happening. There is a femoral loosening as well. And if you look into the abductor mechanism, it's not working at all. So this is the problem with the patient comes.
Why do you say there's pelvic discontinuity here?
There is an impending pelvic discontinuity, I say so.
So yeah, I agree with that.
Yeah.
The other thing you want to pay attention to is the vessels, because that cup and the screws are going.
So we're working on the CT scan. So these are CT scan sections. So there are areas where protrusio has grossly gone in. We do still have columns which are weak. They are slightly supportive, but not so. And that's a 3D analysis. So a couple of pictures of a 3D. We do have a bone there. But as you go more medially, that's a protrusio. That's the head coming in with the screws. And that's a 3D reconstruction.
Get the angiogram done first, the peripheral angiogram.
Yeah, Adesh, what do you want to do? Yeah.
Just to make sure that the vessel's nowhere nearby.
You want to do
be adherent as well.
You want to do a CT angio?
Yeah.
CT angio.
So they want to do a CT angio. Have you done one?
We didn't do it, but I think that's a good idea.
Yeah, just go back to the X-rays for a second, please.
Go back?
Yeah.
You go back? Okay.
Yeah. So
Yeah.
that's fine, that's fine. You see this thin rim of bone that's forming, that's remodeled bone.
Absolutely.
When you find that bone, there's no pelvic discontinuity.
Yeah.
That's a usual rule of thumb that you're not dealing with an instability here. Otherwise, bone remodeling cannot occur on the background of instability.
Absolutely.
So that's a clue that probably not that. It's not a 100% rule, but it is a pointer. Okay, go forward, please.
Yeah. So the question here was to do with the acetabular loss, then the femoral loss, because there is a gross osteolysis in the femur. There was a fracture in the medial calcar and as well as gross loosening. So that's an exposure because there was an already a small crack there. So we actually extended the crack.
Before you tell us what you did, yeah, Mahesh, what is your option?
Thinking from the acetabular side, I think that shell of bone on the medial side is a bit reassuring, and I think probably classify it as 3B without discontinuity. Either if you have access to bone grafting into that defect, or an augment followed by advanced ingrowth option cup, bring the hip center of rotation down. On the stem side, obviously an ETO probably just to improve your exposure, as well as take out the cup and the stem will make life much easier. We need to see the bone looks patulous, but I still think that we will be able to get away with a tapered fluted titanium stem.
Ed, what would be your option in your place? Yeah.
So I believe that this bone density is not good. I think that a unique, a monoblock cage is what is needed with bone graft behind it. It needs a long stem prosthesis that extends at least 2, maybe 3 cortical diameters distal to that pedestal.
Yeah.
Okay, so tell us what you did, yeah.
I think there'll be a difficulty in getting past the pedestal as well when we're doing the stem.
Stem, yeah. So I think we are focusing on the socket side now, yeah, okay.
Yeah. So exposure essentially would need an osteotomy. We had to put the abductor mechanism with a short osteotomy because there was already a small fracture there. We actually elevated it up, and that's how you are able to actually reflect it up. We were able to remove that stem with that skirted head out there. Because there was an impending pelvic discontinuity and we think that this probably might be dangerous, so we removed the cup and the screws and implanted a larger diameter cup on the medial side and treated it like a cup cage construct. So over that, it's a cage which has been put in, impacted and then filled with screw and grafted. And finally, we would cement a cup onto that and then use a long stem, fully porous coated stem, and put that osteotomy fragment back. We were not able to bring it absolutely down, but we were able to restore the abductor mechanism quite nicely.
This is the classic Mayo hemi cage, yeah?
Yeah.
So what does the panel think about it? An ideal option for this case?
The hemi cages are becoming popular, and I think with problems of fixation in the ischium, I think it probably is a good idea to have an ingrowth surface like a T-Mars or a Gription, and then use a half cage.
Are there any
That works
screws in
very
your
well.
cup, IPS? I don't see any screws in your cup.
No, no screws.
No screws. You
No
just
screws.
put the cup like
Just
that.
impact it in.
My only question is, where did you get that cage, or did you
Yeah.
cut the cage?
He cut the cage.
You cut the cage actually. You don't get it, you cut it at.
Socket side, I think it's good. I probably would have used a little longer stem, slightly longer.
Yeah, so it was
I think-
going around 4 centimeters down, so I thought it will, long stems we are not very keen nowadays to actually go it. It's a very nicely fitted porous stem.
So Amar, what do you think about the technical, how is it good from a technical standpoint?
Yeah, I mean, I think obviously a challenging case. I probably would have gone with a custom triflange on the acetabular side. What he did was a very good reconstruction given what he had available. I would have liked to see some screws in the cup inferiorly. That could help a little bit. And then I agree, the stem is a little short for me. So that would be, I'm concerned about a periprosthetic fracture there.
Yeah, we have Dan. Can you give us your comments? Because it all came from Mayo, this Hendrick concept, this hemi cage. Could you comment on this X-ray? And
There's lots of ways to skin a cat, but when we do the cup cages, generally speaking, we use a highly porous cup that we can drill screws through. So that way we can put screws through the cup, fix the cup, then put a cage, either a hemi cage or a full cage over the top of it, and then more screws through the cage, through the cup, and into the bone. So you get a lot of fixation of the entire construct above and below the discontinuity if it's present.
You think tantalum's better?
I don't know if tantalum's better than titanium, but something you can drill all the way through.
All right.
They make both now, different companies do.
so I think the screws are very important because the cup needs to be stable for it to ingrow. You can't leave a cup in and then, in floating in air. So that's the probably. And then, of course, you've got a good hemi cage. And as Dan said, as much of fixation as you can. And then you will get osseointegration.
Yeah, thank you.
Okay?
Yep.
Very well done, IPS. Thank
Thank you.